Hello. Hello. Hello, do you hear me?
Now you can hear me, I guess.
Yes, I hear you.
Yeah.
I hear you very well.
Hello. Yeah.
Hello, how are you?
Very good.
Nice to see you today. Nice to see you.
Yeah, the same to you. So
Yes.
this is
So it's a nice opportunity for neurosurgeon to hear about innovation in ultrasound in neurosurgery.
yeah,
We need that. We need to hear new things, innovation, and not that expensive things. That's
yeah,
it's just the goal. Make doing more with less.
yeah. I think ultrasound is able to do that actually. Absolutely.
Hello,
Hello,
John.
hello.
The webinar is will be streamed in streaming on Neurosurgical TV and on YouTube too.
Mm-hmm.
So just
yeah.
I'm looking for something.
That's good.
You wanna try your slides?
I think it's okay.
Okay.
Yeah. I could try to see that.
How you doing, Fod?
I'm good. I'm good.
Yeah, everything's good. I don't have to be here. I'm going to leave. I just came in to say hello and good luck.
Hello. Thank you so much. Thank you so
Okay.
much.
I'll see you.
Thank you.
Good luck.
Bye bye. Bye bye.
Bye-bye. I can test to see that everything functions.
Yeah,
Share
yeah,
screen.
please.
Yeah.
Okay, leave. Okay, leave.
Share.
Mm-hmm.
Is it okay now or?
Perfect.
Perfect. Yeah.
Yes.
That's good. That's good. Then I will stop sharing.
Okay, Gavin, I see you managed to join. Sorry, I've managed to come on as well.
Hello.
Good.
Hello, Levin. How are you?
Yeah, I'm good. Well done. Okay, Gavin, you happy? I see your slides did show. Let me try mine quickly as well. Sorry, Fad.
Yeah.
Yes, please.
Great. Let me just open my talk first. To remind me, how long do we have, Fad? I said it for about 20-25 minutes, but
it's on between 30 to 20 minutes. It's up to you.
20 to 30 minutes. Okay, great. Just check this quickly. I can share. You've given me ability to share. Yeah, it seems like I have.
I think I'm close to 30 minutes actually.
Okay, great. Can you see that, guys?
Yes.
Okay. Good.
Mm-hmm.
We're good?
Yep.
Okay, great. I'm going to stop sharing then. All right, Fad, so we're here. Just wait for you and you let us know.
How many has registered? How many have registered, Fad? You know? No.
Not yet for me. I don't. Do you see me? Hello?
Yeah, no. Yeah. I see.
I had the connection problem. It's not good.
No, I see only an image of you, not real, not live.
Yeah, a younger image of you, Fad.
Yeah.
Much younger.
Don't be mean, Levin. Yeah, it's because of Barcelona. Like last time I got, we eat lots, huh?
Mm. But I see Alexandra's
Hello,
joined.
Alexandra.
Hi, you, Alex. Good to see you.
Hi, everyone.
Hello.
I also had some connection problems, but I think it's okay now.
Yeah, nice to see you, Alexandra.
Good to see you.
It's a long time since, yeah.
Yeah.
You have been to Rabat several times?
Only once
Only once, yeah.
so far.
Yeah.
Fad was a wonderful host.
Yeah.
Yeah, you deserve it, and it was nice to have you in Rabat, and everyone enjoy your talks, your sharing of science and everything. It was really nice. And you are welcome whenever you want, and it's the same for you, Professor German, and for you, Levlin.
Thanks, Matt.
Thank you very much.
While I have the two of you, Gammon and Alex, Zandra, I have sent to the WFNS, the scientific chair, a program that includes both of you. Remember we spoke about doing some sort of ultrasound-based navigation workshop. That's on the 4th of December, the morning. Just wanted to check with you. That's okay. If you haven't already, then you probably will get some sort of invite from the organizing committee about that. Yeah.
It's in the middle of, it's the first day. Is that the first day?
That's on the 4th. Yeah. So the program starting at like 4 o'clock on the 4th. And because of the number of pre-congress workshops, I thought that would be a great slot that Monday morning. So we have an ultrasound meeting then. We finish off at about 4-ish, and we can then move across to the welcome reception. Otherwise, we cluttered and competing with quite a few other skull base and endoscopy, and you don't want to be doing that. So at least Monday gives us a slot that's not exclusively ours, but more ours.
Sounds good.
It is good for me as well. Thank you for inviting Llewellyn.
Yeah, no, fantastic. That should come soon.
So you are in Boston now, Alexandra?
Yes.
Yeah. It's good temperature. It's nice summer in Boston, I guess.
Well, we've had very hot and kind of cold for June, but that's sort of New England. It's up and down. Yeah. Today it's very gloomy.
We had a sudden change here from very cold weather to very warm weather now. Our warm weather is not that warm as yours weather, but we are very satisfied with the temperature above 20 degrees. So that's good for us. So summer finally came. Is this an open? There is no registration beforehand.
Yeah, no, we have a registration. We have almost 150 participants registered, but we need to wait them to get to join us for the webinar. I'm trying to. And
they will be asking questions in the chat, or how is that going to happen? Or will they be asking questions?
It's on the chat, but if someone want to ask a question directly, why not?
Yeah, that's good.
Why
that's
not?
Good.
Yes, this will be good. It will be good. It will be good. Maybe you can plan your visit to Rabat, Alexandra. If you can plan your visit to Rabat during next October. We plan to have a ultrasound course here in Rabat at the university. This will be great.
Yeah.
I know that it's challenging, but it just
October what?
this October.
Just October?
Not this
This
time.
October, yes.
In what day? What date?
We will have meeting next week, and we're gonna fix the day.
Mm.
It will be,
I
it will be
think
our annual symposium of the university.
This Alexander, you know this group that are making courses in all over the world, and this is the group that are going to FAD's the hospital in October actually, and make a new course.
Oh,
there.
I don't know. Which group is that?
Well, it's Lebelin is in that group, and Aliaskar Moyadi, and also Francesco D'Amico and Francesco Prada.
Hmm.
And I am in the group, and also Nahed.
Brian, go ahead.
Brian Nahed. He wanted to make a course in the United States in the fall sometime. So we will have to discuss that also on the next week, I think.
Okay.
Mhm.
Did you receive the flyer, the new flyer of the Young Neurosurgeon Award? Do you hear me?
Yeah.
Do you
Who were
receive
you addressing?
Yeah, to everyone,
Yeah.
to the group?
Yeah.
Because I'm sure I sent it to everyone.
Yeah. We got it on
Yes.
on WhatsApp. Yeah.
Yes.
It's good.
Great. It's good.
Yeah.
So in 5 minutes we can start the webinar. We are waiting. We are waiting just participants to join us, and we'll start our webinar.
Just a quick question.
Am I audible?
Hello, hello, Sashan. How are you?
I'm fine. Hello, everyone. And Alexander.
Difficult to hear.
Okay, Fahd, perhaps I can ask you, so what's the format of things going to be like? I mean, just in terms of, you said people introducing each other, just, do you want me to introduce Cameron, you said? Is there a format? Or how's that going to work?
It's up to you, huh? You know German, but it's I send you the short CV of German.
Yeah, I've got.
Yes.
You just tell us who must do what then. Okay.
Yes. So I will start the webinar, and then both chair you will manage this the next part. I send you a brief scenario.
That's good. Yeah, thank you for that. I think Evelyn, you are going to take over after I finish my talk, and then ask some questions and so on, and then give the floor over to the next ones. So isn't that true? Isn't that the way it's going to be done?
I think yes.
Yeah,
I think so. Okay. We can start the webinar in 1 minute. What do you think, guys?
Yeah.
In
Time
1
is
minute.
up.
Okay.
Yeah, so it should be okay.
Yeah. Okay. So let's start the webinar. Hello, dear colleagues. Welcome. The WFNS Young Neurosurgeon Award Committee is pleased to welcome you for another webinar about innovation and research. We are happy to celebrate the excellence in research in neurosurgery. The main goal of our committee is to define the 5 best papers of young neurosurgeons at the World Congress and to invite all young neurosurgeons to submit their original and unpublished paper for this competition to receive one of the 5th Anatos de Souza Awards. Don't miss the July 31st deadline for submission. And today, we have an excellent topic representing innovation.
You missed your FAD. Don't hear you anymore.
Can you hear me?
So I can hear you. I think it's just fog. Yeah.
Yeah.
Okay. Well,
Research and neurosurgical care. Today, I'd like
okay. Why don't I go ahead and
So-
introduce
Yeah,
Dr.
go ahead.
Padilla. So it's my pleasure to take part in this symposium, and particularly my pleasure to introduce Professor Llewellyn Padiachi, and I'm sure I didn't pronounce that correctly, who is full clinical professor and head of the neurosurgery department at the University of Pretoria in South Africa. He's the chief specialist and pediatric neurosurgeon at the Steve Biko Academic Hospital, also in Pretoria. And Professor Padiachi is internationally recognized for his expertise in minimally invasive surgical techniques in pediatric brain tumor and hydrocephalus surgery, as well as for pioneering non-invasive diagnostic techniques in detecting raised intracranial pressure in children. And he is going to speak to us about some of these very interesting clinical applications of ultrasound.
Okay. Alex, thank you very much. And as you know from experience, a lot of those introductions say a lot of things about you that you wonder sometimes, where people get them from. But anyway, thanks so much. And hopefully we'll touch on a lot of the points that Professor Golby has highlighted. I'm just trying to get to the point where my slides. Okay, there we go. Is that good, Alex? Can you see that clearly?
It's great.
Okay, great. So what I'm going to talk about, which is something I think all of us agree is particularly relevant, I think increasingly around the world. It doesn't really matter where you are. The applicability of ultrasound seems to have come full circle now, and I'll show some of the historical significance about what I feel quite strongly, that the first description of the use of ultrasound in medicine was actually a neurosurgery/neurology description, and how cardiologists and obstetricians and primary care physicians have really embraced ultrasound, and we've lagged a little bit, but I think we're catching up quite nicely now in the context of kind of the use of ultrasound in neurosurgery. So again, thanks to Professor Golby for the warm introduction, and to Fard from the Young Neurosurgeons Award Committee who's put this together. Thanks for all the effort. And then an acknowledgement to Professor Ungsgaard, who really has driven this more than, as far as I'm concerned, anyone on the planet, and has really made massive contributions in terms of not just image guided surgery, but also advances in our thinking in low-grade glioma surgery. So disclosure is I am a medical advisor to a company called Nisonic, which has really been an offspin from a lot of this work that I'll show now. And I quite like this slide if you look at it, just to highlight the fact that a lot of these courses and talks, even though Professor Ungsgaard will show we've run really around the world now, there have been a number of them which have run on the African continent. So if you look at the Cairo on the left there, Addis Ababa, Abuja, Pretoria, where I'm based now, and then Cape Town. And I particularly want to stop there for a second just to highlight the fact that the World Congress of Neurosurgery will be held in Cape Town, running from the 4th to the 8th of December. And there will be a number of really innovative talks as well, but really pre-Congress workshops. And we plan to run one based on the use of intraoperative and other uses of ultrasound in neurosurgery on the 4th of December. So please keep your scanners peeled for those, and please try by any means necessary to get yourself down to this event, which is promising to be quite a landmark event. These courses are run by a number of us. Gavin Ungsgaard, most notably, who's driven this, and then you'll see Francesco De Maker, Ali, Brian Nahed, myself, Alessandro, and Francesca. And the goal of this is just to drive the usefulness of ultrasound in the context of neurosurgery. So for me, the most appropriate quote that governs how ultrasound is used comes from an ex-American president. So Eisenhower is famous for stating that in preparing for battle, he's always found that plans are useless, but planning is indispensable. And I think if you look at the context of navigation in neurosurgery, the more we've used this, the more we've realized it's great to plan our entry point and prepare our craniotomy. But as soon as you open the brain, particularly in things like multicystic hydrocephalus, any sort of navigation becomes really irrelevant. And in that context, ultrasound is really the only real-time imaging modality that allows us to update our imaging. Intraoperative MRI scan for sure, but that comes with a huge amount of baggage, financial and logistic. So I think the attractiveness of ultrasound is something that almost sells itself. So a quick background: diagnostic ultrasound really for our purposes ranges from 2 to 18 megahertz. Therapeutic ultrasound, which I've included here, but really for the for the sake of the talk is really for complete sake, ranges much lower frequency, but has been used to treat certain types of neurosurgical diseases, ranging from essential tremor to opening of the blood-brain barrier to actually treating lesionectomies in certain types of tumors. The basics, I think, are always important. Sound is a form of energy, it propagates, and if you look at how this propagation differs in different types of tissues, forms really the basis of ultrasound and how we interpret it. These particles are stretched repeatedly and compressed, and they have different energy components as they pass through tissue. And these alternating bands of compressions and rarefactions can be mathematically converted into a wave. And I think that perhaps oversimplify something as complex as what ultrasound translates to. It's also important to bear in mind that when you compare it to things like CT scan, which has a cumulative radiation effect, particularly on the developing brain, MRI scans in children, almost all centers that perform the MRI scan now, are based on some sort of anesthetic or sedation effect. And this also has a cumulative effect on the developing brain. So ultrasound in this context is incredibly attractive, but also has certain things you've got to be aware of. And these bioeffects are dependent on the intensity of the beam, the duration of exposure to ultrasound, the scanning mode, and the frequency used. And there are two main areas of concern for ultrasound safety, and these are thermal and non-thermal. So the thermal effects is when ultrasound travels through tissue, the energy is retained by the tissue components, and this is converted to heat, and this can affect the rate of chemical reactions importantly. The non-thermal effects are things like cavitation and streaming, and these relate to the expansion, contraction, development, collapse of bubbles during the oscillatory cycle. The collapse of gas bubbles in the negative half of the cycle also releases some tissue into the local, releases some energy into the local tissue. Streaming relates to the movement of complex fluids due to radiation force pressures, and these are also something that we've got to bear in mind. So how do you interpret these kind of complex sort of physics-related things? Every ultrasound machine now is obliged by the FDA to indicate two indices. The one is the thermal index and the other is the mechanical index. So a thermal index of 1 effectively indicates the condition under which a rise in temperature would be likely to 1 degree of Celsius if you use the ultrasound at that energy output. And all safety statements at the moment advise that the total temperature increase in tissue should be kept below 1.5. So effectively, if your thermal index is below 1.5, you're okay. The mechanical index attempts to predict the likelihood of non-thermal or mechanical damage. And as long as you stay within the safety regulations of the thermal and mechanical index, using ultrasound on the brain is completely safe. So I mentioned earlier, the earliest medical descriptions of the use of ultrasound was by a neurologist. The Dusik brothers, most famously Carl Dusik, was the first physician to describe the use of ultrasound. And if you look at the image here, he thought he was imaging a brain tumor and ventricles, which is quite understandable. It turns out it was completely artifactual. But still, he's credited with the first description of this. Ian Donnell then really pioneered and drove the implementation of ultrasound in obstetrics, and we know it's a fundamental tool for any obstetrician nowadays. So what is this versatility that I speak about in terms of ultrasound use in neurosurgery? And I think it ranges from diagnostic capacity, so at the bedside, conditions like craniosynostosis, hydrocephalus, tumors, raised ICP, and I'll spend a bit of the talk just unpacking that. Then the intraoperative component, conditions like hydrocephalus, to place VP shunts, to guide endoscopic fenestration of multiloculated hydrocephalus. I'll show some examples where ultrasound can be used to govern at least as a quality control mechanism for bony decompression in Chiari-1 malformation. Tumors, I'll start off, but really Gammon will show a lot of the advances in tumor imaging. Vascular lesions, I'll show some of the benefits, and peripheral nerve surgery, which is a growing attractive component for ultrasound, something I don't have any sort of experience in, but certainly more and more of the publications suggest it's useful. As a surgical tool, it's important to bear in mind that both the CUSA and piezo surgery are both ultrasound-based technologies. I'll touch on some of the advances, things like elastography, and strain, so shear wave elastography, contrast enhanced ultrasound, and then 3D ultrasound, which will be a nice sort of kind of handover to Professor Ungsgaard's lecture. I, for completeness sake, mentioned therapeutic ultrasound, particularly the high intensity focused ultrasound, and I know for a fact that Professor Gorby's unit has tremendous experience in this kind of, it really sort of research and translational modality, but I think is fast becoming an attractive, non-invasive way for treating certain types of tumors, functional conditions, and opening up of the blood-brain barrier. So in my practice, and what I focus this talk on, is the use of ultrasound in a very practical way. And I think that's important if we look at the context of this particular discussion. So I started off, with describing this in this context, and some of the examples will show that. Things like guiding ventricular catheters, guiding as a quality control mechanism for tumor resections, endoscopic fenestrations, multiloculated hydrocephalus, vascular malformations, Chiari-1, and intramedullary spinal cord tumors. So the ergonomics of intraoperative ultrasound are important, and I think you've got to bear in mind that as you use it more and more, the flow in theater becomes fundamental. So the way you position your ultrasound relative to the screens that show the endoscopic fenestrations, when we do lavages that are guided by, or endoscopic lavages guided by ultrasound, it's a 6-handed technique. It's important to bear in mind that the technology and the software are advancing at phenomenal rates. So, there have been a number of companies using probes that are connected to tablets and cell phones, and the quality of image on these is really, really impressive. And I think the more I look at these, the more I realize how it's becoming a mainstay, even in the intraoperative sort of environment that we're in. So the equipment, like I said, is really from big bulky machines like this, is moved all the way down. This is the BK machine, which is really embedded itself in neurosurgical ultrasound usage, and then the tablets and finer sort of ultrasound guided techniques. So what are the necessities? Very briefly, this is is almost a discussion on its own, but you need an adequate dual window. You need to have a protocol put in place so the sterility of the probe, depending on the machine that you use, is always checked meticulously. The image quality, which has always been a sticky point, the image quality and display for neurosurgeons, because we trained really in the CT scan and MRI scan era, where all images are either axial, coronal, or sagittal, and ultrasound almost teaches you to think in a sort of orthogonal type dual or any plane type of imaging, and you've got to get used to it. But I think once you've retrained your brain, which doesn't take a lot of effort, when you use this more and more, it becomes almost fundamental to your sort of intraoperative routine. So I'm going to start off with the bedside diagnosis, and I'm a pediatric neurosurgeon, so I have focused a lot of the talk on that. One wants to decrease the amount of unnecessary CT scans, particularly in kids. You need a technique that allows you to pick up the early diagnosis of anything causing raised pressure in neonates earlier. We need something that allows us to follow up the assessment of ventricular size, particularly in patients who've had a VP shunt. The advancement of POCUS, of point of care ultrasound in the emergency department, has become a big focus. Things like the optic nerve sheath diameter is something I'll spend a bit of time on. We spent quite a bit of time trying to define these parameters, so ultrasound plays a fundamental role there. So what's the value? This is a typical, snapshot of a child treated in a pediatric hospital with hydrocephalus. So 15 CT scans in 5 months in a 6-month-old child. What does that mean? So the effective dose calculates in millisievert the amount of radiation a child or adult for that matter is exposed to. So for a chest x-ray, it's the equivalent of 1 day's worth of background radiation. Skull x-ray, 5 days. A CT head, 8 months worth of background radiation. So one CT is effectively the equivalent radiation dose to a child of 100 chest x-rays. And we know that at least a third of kids will have 3 CT scans before the age of 15. And a study published in The Lancet a number of years ago showed that 2 to 3 CT scans in a child under the age of 15 triples the lifetime risk of brain cancer. 5 to 10 scans triples the risk of leukemia. So we've got to be aware of how one images. And in this context, ultrasound is a very attractive, non-invasive way of diagnosing raised pressure. And in our setting, and in mine anyway, the vast majority of children we treat present much later than they should have, and raised intracranial pressure is the commonest underlying feature. So our work at the time aimed to identify viable methods of diagnosing raised intracranial pressure earlier, validating them, and hopefully refining them. And this need for a reliable non-invasive ICP assessment tool became clear for reasons I've explained earlier. We all know that CT or MRI scan have certain described imaging features which assist effectively. Clinical assessment is a blunt tool, but so is radiological assessment. So if you combine these two blunt tools, presumably they refine your diagnostic accuracy. But even then, the need for a reliable, non-invasive technique outside of these two to diagnose ICP is critical. And if you summarize them, the clinical assessment, radiological assessment, techniques using the natural bony window, so in kids, the fontanelle, in adults, transorbital or through the ear, fluid dynamic techniques, most notably there would be your transcranial Doppler, and then electrophysiological techniques, visual evoked potentials, and EEGs. So we went through all of these and found the transorbital ultrasound-based measurement of the optic nerve sheath diameter to be the most reliable, or at least easily reproducible at the time. The technique has been described. For those of you interested, these 2 papers by Raoul Stevens are really the fundamental core reading. They really unpack the anatomy of the imaging. They help you interpret what is thought to be the optic nerve running through you, the hypoechogenic stuff, the fuzzy, hazy, hyperechogenic
I think we lost Levlin.
Hmm.
He will get connected for sure. He's coming
We'll,
back.
Give a
Yeah,
minute.
he's coming. Yeah.
Action.
Uh,
Complete disappearance of connectivity was there. So sorry about that. If I can try that again, tell me if you can see that, Fahd. I can.
yes. Go ahead.
Great. So this is a scan of a patient we treated with a collection there. That's what the optic nerve sheath diameter looked at the point. We then repeated the optic nerve sheath diameter. You can see it increased, repeated the scan, and the bleed had increased in size. The patient also neurologically deteriorated during that time. So it's not a standalone. And I mean, if you look at more of the publications suggesting that this is a technique with a good diagnostic accuracy, some support it and some don't. But we've certainly found it to be very useful as a screening tool, particularly in the critical care unit. And we published this, it's quite a large series, trying to define cutoff values in children with a closed fontanelle. And these show reasonable diagnostic accuracy. You can see that's what it shows, area under the receiver operating curve. Good sensitivity, not that great specificity. That's kind of what you'd prefer in a tool designed for this sort of thing. This was then repeated about 2 or 3 years later by the group in Tübingen who repeated the optic nerve sheath diameter measurement in awake kids. So ours were all done in asleep kids, anesthetized, waiting for insertion of an ICP monitor, but it was good to have an independent publication almost verifying those values. So the limitations of current diagnostic or non-invasive techniques are user variability, diagnostic accuracy, quantitative estimation of ICP. So you want something that gives you, a value rather than an estimate of high, low, or kind of medium. And you want something that allows continuous real-time data. So those are still elusive at the moment, and there's lots of work ongoing. We're involved in some of these. I'll show some of the publications. So we've described a technique using pulsation of the optic nerve sheath as a marker of raised ICP. And this publication shows that if you combine this technique with the existing ONSD, it does refine the diagnostic accuracy somewhat. We also found ways to almost use a sort of park assist technique to kind of take away the user variability. And because of punching this data into mathematical or machine learning algorithm, we were able to segment out the globe and the optic nerve and the optic nerve sheath, which goes away to improving the diagnostic accuracy of the technique. Other valuable techniques here, the optical coherence tomography. You can see what that looks like in a normal versus a patient with raised ICP. In my opinion, probably the best imaging technique of the sclera. The difficulty is it can't image beyond the sclera, so it doesn't really tell you what the nerve sheath looks like. A big setback there was the fact that all patients needed to go into the, I'm going to close my camera now because it's dark behind me anyway. You had to move patients to the actual room, and now recently they've developed a handheld OCT technique, and I think this is going to probably change the game significantly. Transcranial Doppler, there's lots been published on this. I've just included it for completeness sake, a very ultrasound-based technique, but the data still suggests that it's a good qualitative estimate of ICP, so it can tell you what's normal, low, normal, and high, but there is some disparity regarding its absolute relationship with ICP. So likely useful as a first-line examination in the ED, but doesn't really give you a good quantitative estimate. Okay, so that's the diagnostic stuff. I know I've summarized it quite a bit, but I've tried to also keep to time as much as possible. Intraoperatively, the modern neurosurgery theater, I think a lot of us would agree, has become larger and actually quite intimidating for the more we invite people in, engineers and other associated adjuncts. We realize how complex the neurosurgery theater has become. We have navigation systems, minimally invasive techniques, intraoperative image guidance, intraoperative monitoring techniques, whether it's cortical or neurophysiological mapping. But finding a structure, and I think this has been kind of my bias here, that sort of provides a good overlay between structural and functional monitoring. So functional monitoring obviously being your intraoperative neurophysiological monitoring and the usual strategies there, but combining that with a neuronavigation and some form of intraoperative imaging, and we obviously have a bias towards intraoperative ultrasound, is really a great way to approach this. Intraoperative neurophysiological monitoring, the techniques are not kind of the fundamentals of this talk, but I think a lot of the audience are familiar with the principles. And I'll show an example here of how we've combined these two techniques quite nicely. So we use the kind of mapping suction probe, which helps us to map a good area, the tumor I showed earlier, and this is what the imaging looks like intraoperatively with the ultrasound. So we're able to get the structural component combined with our functional mapping and monitoring, which really, I think, if you refine that, provides the best available kind of option for safely resecting these tumors and minimizing the morbidity. That's the post-op, and this is another kid, with a huge tumor. Using the same technique, we managed to remove completely and minimize the morbidity. Okay, so the ideal navigation technique, I've mentioned the benefits. I'm not going to belabor that too much. I've shown this already. What I wanted to show you was the types of probes, and I think this is a question that's come up quite a bit. So, some would ask, if I have, and virtually every hospital has an ultrasound system. So do you just need to buy a new probe? Do you need an additional system? I think we'll leave that for the discussion at the end. But the probes nowadays, effectively all are, fairly high frequency probe. They tend to be either phased or linear array. The portable held hand units now, like I've pointed out, are also providing really spectacular quality images. And there's such a variety of them now. All the big companies have really embraced, or most of them anyway, have embraced this move towards a smaller kind of portable handheld unit. Just to underscore the benefits of the imaging, this is the child with a supratentorial ependymoma, which we resected without the use of intraoperative ultrasound at the moment, at the point, just the microscope. Thought we did quite a good job resecting it along the ependymoma. Resected everything that I could see, but you'll see on the follow-up scan, this is uncontrasted, and the reason was the kid's renal had some form of renal impairment. There was probably some residual tumor that I couldn't see. The follow-up image at 6 weeks shown that there was quite a bit of residual. Some of it may have been recurrence, but the argument I make there is if I'd had intraoperative ultrasound, I probably would have picked up that residual and removed all of it. And I think that makes the point quite usefully. So what's the quality of imaging? I think we want to be able to localize a tumor correctly. So this is what a coronal MRI scan looks like. You can see the quality of the imaging on ultrasound. This is just 2D ultrasound, is really comparable. An intraventricular tumor, coronal MRI scan, you can see the quality of the imaging on the ultrasound. It allows you to measure the thickness of the cortex, the length kind of from your incision all the way down to tumor, how much ventricle, and the kind of parameters of the tumor itself. This is a choroid plexus papilloma that involved the lateral and third ventricle. You can see the vasculature on the MRI scan, but you can see how ultrasound Doppler function allows you to delineate that vessel beautifully, in real time. So you can follow that vessel, you can follow your resection, and whether you use full Doppler flow or just power Doppler just to see the vessel, like I'll show, makes a massive difference to the quality of the imaging. This is a child with a posterior fossa tumor. During the resection, I thought I'd removed most of it. You can see the imaging still shows what may be some residual tumor. So I resected those margins. You can see the imaging here nice and crisp, and I was happy to accept that there was a complete resection, and you can see the floor of the fourth ventricle, the aqueduct, all the way up there. It's quite nice to get that additional quality check intraoperatively. So for complete resections, you can see quite nice. I'll show 2 complete resections. That's what the post-op MRI scan looked like. This is lining the cavity with Surgicel. You can see a nice clear ultrasound, always reassuring when you have that. What about intraoperative residual? This is the patient where I knew we couldn't remove all the tumor because the patient became hemodynamically unstable. You can see the tumor here. Confirm the volume on ultrasounds. When I did the post-op MRI scan, none of this is a surprise. You know exactly what you're going to get on the post-op MRI scan. About spinal tumors, this is a patient with a sort of cervical spinal cord tumor. You can see what it looks like on the MRI. Nice delineation on the intraoperative ultrasound. We removed all of that. You can see the cavity. This is just collapse of the cord, and nice complete resection. So the type of probe you use differs. So we use the hockey stick small footprint, high frequency probe for spinal cord. It just images beautifully. It'll be interesting to hear what others use. The vascularity power Doppler is incredibly useful. So this is the posterior fossa tumor. You can see the two picas here. So it helps you differentiate, tumor vessel from adjacent vessel. And it's always quite nice post-operatively just to make sure that your picas are still there. Whether you use it in a research capacity to measure the flow or flow velocity is also a very attractive tool, but again, not mandatory, just a sort of attractive research component. Limitations, I've pointed some of them out before, but this artifact at the base of the tumor cavity at the end has always been a difficult thing. And that's what it looks like with normal saline. Gammon, who's driven this tremendously now, will speak about the acoustic coupling gel. And you can see something like that would take away this artifact, would make a massive difference in our sort of appreciation of what we think is a limitation of the technique at the moment. Comparing it to post-op MRI scan, there are lots of publications suggesting a very good correlation. This work by Ali Asghar Moyadi, who's part of the team that is driving the kind of adoption of ultrasound into neurosurgery, showed that when you compare intraoperative ultrasound, it compares very favorably. In fact, in some ways, outperforms the MRI scan. And these are just kind of workflow, surgeon convenience types thing. The lack of a need, if you look at it, significant for the MRI scan, but virtually negligible for the intraoperative ultrasound. The advances, things like contrast enhanced ultrasound, and Francesco Prada is probably one of the world leaders at the moment looking at the applicability of contrast enhanced, and he's got a very elegant way of describing it. Would we use just a T2 and a T1 MRI scan without contrast? And the argument would be no. So, by that same token of thought, if you look at contrast enhanced ultrasound, he feels it's becoming very much the kind of multi-parametric imaging modality for ultrasound. Probably still, I would argue, in some sort of research capacity, the elastography, things like strain and shear wave, are really attractive. We've started using them now, well, not routinely, but as part of research projects in our unit, where we get elastography pictures on all our types of tumor and then correlate it with the histology, and that's really kind of master's projects for some of the students we have. But I think there's lots of potential there to help differentiate tumor borders, to help differentiate types of tumors, metastatic from primary, and the value of that, I think, is significant. Extended indications, so outside of tumors, we started off in pediatrics, so this is a kid with small ventricles, I think intimidating for any neurosurgeon. And this is what the real-time ultrasound looks like. So you can see with the ultrasound placed open the anterior fontanelle. This is a sagittal view showing the catheter placement under real-time guidance. And there's no other imaging modality that gives you that quality of real-time guidance. So I thought I'd place the catheter in the ideal position, flip the probe around, and you can see in the coronal view I was more lateral than I thought. So it gives you that ability to correct that. And there's no other imaging that allows you to do that. So there's several groups that have looked at this. The Hydrocephalus Research Network have evaluated ultrasound use, and they found that the routine use of ultrasound-assisted catheter placement is an option, and the strength of the recommendation, was unclear. Some of the work from Germany suggests a lot more kind of bold statement, where they say that ultrasound-guided ventricular catheter placement should become the standard of care in VP shunt surgery, and their data do suggest that that is an option. For neuroendoscopy, something I've spent quite a bit of time with, and I think the benefit, like I've said, I think navigation is great for planning your entry point, perhaps your first, maybe even your second fenestration. But by the time you get there, navigation is completely useless because there's no way to update those CSF and brain shifts. And then ultrasound really is a valuable adjunct. And I'll show, some of the work that we've done. Work from Israel suggested that you have to have some sort of intraoperative imaging update. They described use of the MRI scan, found it to be quite useful, but I know the team very well, and since then they've also admitted that using the MRI scan was a bit of an overkill for this, so they've moved away from using it routinely and use the ultrasound more now, just from a convenience point of view. This paper published by Martin Stravitsky back in 2002, described this ultrasound guided endoscopic fenestration. He found it to be very safe. It gave him permanent visual control, real-time imaging. He described the saline flush technique, which we've advanced on a little bit, and I'll show some of our images in a bit, and recommended this ultrasound guided imaging to update the fenestration. So this is typically what our setup looks like at the moment. You can see the ultrasound, the endoscope views, and I emphasized this earlier on. The more you use it, the more you find the workflow becomes ergonomically viable. So line of sight, ease of use. Like I said, I've got 2 registrars assisting, so it's a 6-handed technique. This is something you probably don't see too much in Norway or Boston for that matter, but this is the case that we had to fenestrate, with you can see we had to aspirate a bit of exudate from the ventricle and then fenestrate all of these under ultrasound guidance. And I'll show the value of that. So this is a case where we wanted to define whether, the fenestration was adequate or not. And outside of ultrasound, the only way you can do that is to image pre and then post-operatively. And if you haven't done the job correctly, you've got to go back and open these locules. So this ultrasound guided saline flush technique really helps us to understand which locules communicate and which don't. You can see this little pocket clearly doesn't communicate with the rest of the loculated system. This is a sagittal view. So we inject the saline flush, and you can see it settles over this dome. So intraoperatively, I know I haven't fenestrated this adequately, so I can go back with the endoscope, open this up, and I know I've done the best job available at the time. So this is just some of those images, to showing isolated pockets and things that we've tried to fenestrate. The one on the end here shows one where we've actually fenestrated adequately. You can see the flush goes through into the third and over onto the other side. So I'm quite happy that I've opened that system up completely. And I think as an intraoperative quality check, it's probably about as useful as you get. So we described this technique in the WFNS guide for neuroendoscopy. There's a chapter we've written there. So what about Chiari deformity? And I think, so the purpose of this talk is not a sort of how-to, or algorithm for managing Chiari-1 malformation or deformity. It's just where one's decided that potentially a bony decompression alone may be suitable. Having an intraoperative quality check to assess for CSF flow is quite useful. So our regimen at the moment is one where we do cine MRI scan for all these patients, and where we demonstrate no CSF flow across the craniovertebral junction afterwards. What we would then do is a bony decompression here, place the ultrasound probe over the dura before we open it. And this is quite nice to see the pulsation of the tonsil, but it doesn't really mean much. So what we try to do then is get a power Doppler to see if there's flow around the tonsils. And where we see flow around the tonsils, these are cases we would consider for not opening the dura, because we know the morbidity is directly related to opening of the dura. There's been some discussion about what flow is adequate or what rate of flow. I'm not sure that there's a huge amount of value in that, but certainly some centers have described rates of flow. Where I see actual flow around the tonsils, I would regard that as adequate. And this is another patient where, just to show the spectrum, this is a patient where we did open the dura, shrunk the tonsils, a patient with a syrinx. You can see what the quality of the imaging is here. This is a sagittal again. You can see we shrunk the tonsils. That's what the syrinx looks like. I then decompress the syrinx, and you can see it collapses here completely. It's quite nice to see. I think that's pretty clear to show after it's collapsed. So this same patient then recovered well over the course of several weeks. Suboccipital headaches improved, function in his right hand was better, returned to work, but he came back to our clinic about 14 months later, complaining of nausea, vomiting, worsening suboccipital headache. We scanned him again, and you can see the syrinx has recollected. The tonsils, I would argue, are probably adequately decompressed. That's a discussion we can have separately. We decided then to place a syringo-subarachnoid shunt for him just because of his symptom. And this is something I want to just demonstrate. So we measured the level. Remember, previously we'd taken C1. We screened, thought we were at the right level, opened up, and then just placed the ultrasound to see and confirm where we were. And you can see there's clearly no syrinx here. So if I had placed my catheter in at that point, I would have potentially damaged the cord because I was half a level lower. I then, based on that, took my laminectomy a level up, and you can see once I placed the probe here, a nice sort of healthy ultrasound demonstrating the syrinx. So just to highlight the sort of safety or quality control that ultrasound, provides, I think is incredibly important. Okay, I'm going to end then by saying that this is a beautiful quote by Jay Forbes in Lennox Treatise. And what he said was that at the time that it will ever come into general practice, I'm extremely doubtful, because its beneficial application requires much time, gives a good bit of trouble to the patient and the practitioner. What he was talking about at that point was the stethoscope, and we know how mainstream that has become. So I think the fact that, ultrasound requires quite a bit of teaching and learning, I think is just a side effect for something that will become very much mainstay and standard of care. So to summarize, it's safe, it's cost effective, it's got tremendous versatility, diversity, from diagnostic to navigation as a surgical adjunct, like I've shown, even therapeutic and modulation, and I think still presents an incredible value proposition in neurosurgery, and is definitely worth making the effort to integrate into our routine practice. Okay, thank you very much. And again, my apologies for losing connection for a bit there, but I hope I've made up for time a little bit. Fahd, I'm going to stop sharing now.
Thank you so much for that amazing talk covering so many aspects of the use of ultrasound in neurosurgery. I'm going to open the conversation to any questions that our attendees have. Samuel Kaba has a hand raised.
Yeah, thanks so very much. I'm Samuel Kaba, a professor of neurosurgery. I've been using ultrasound in neurosurgery for the past 1 year in Ghana. And I just want to appreciate what he has presented. But I want to ask a simple question. I've moved away from the regular probes to a hockey stick probe, to look at the hockey stick probe in thalamic tumors and other tumors that I do. And I want to know what is his perspectives about using the hockey stick tumors, hockey stick for thalamic tumors and other places. Because it seems to give me a good result, and I want to know if they have used the hockey stick or not. Thank you.
Okay, so perhaps I'll answer that. So thanks, Professor Kaba. So that is an important question in terms of selecting the appropriate equipment. I think the hockey stick specifically, in my experience, because it's a small footprint, high frequency probe, I found it to be useful, in spinal cord lesions or superficial lesions. For thalamic tumors, the phased array, 8 megahertz probe, again, you've got to practice this enough to find which one you're most comfortable with. I don't think there's a sort of one size fits all, but in my experience, the hockey stick has been very useful for superficial imaging because it's a high frequency probe. Gamond, Alexander, please let me know your thoughts there.
Yeah, I agree with you. It's a high frequency probe with a low penetration down in the tissue, so it will not be very helpful, I guess, in a thalamic tumor. Probably not. You need some lower frequency to get down and see the whole tumor.
Unfortunately, we don't have a hockey stick probe, but my understanding is it can be useful to place in the cavity in the absence of the acoustic coupling fluid that you mentioned, directly against the tissue at the depth of the cavity to avoid some of that artifact. Any other questions? Okay.
Yeah,
well,
maybe
again,
I can continue here. Okay. Maybe you give me the point. Now, we use ultrasound for hydrocephalus and for many diseases that we think that ultrasound could be good. And when we are operating on all kinds of tumors, we use the ultrasound to make it live. I don't know your experience, but I just want to know. For instance, if you're dealing with deep-seated tumors and you use the ultrasound, does it help you to really resect all the tumor?
So maybe I can make a comment there. I don't think any tool is designed to
No,
help.
excuse me, before you answer, because in Ghana, we don't have intraoperative MRI, okay? My center is well developed for everything, but we don't have intraoperative MRI. But then I try to use the ultrasound as intraoperative MRI. They are two different things. Let me agree to that. But when I use it, I try to resect the tumors based on the ultrasound images that I get. And fortunately, we do it by ourselves as neurosurgeons, not the radiologists. We go in and we use the ultrasound. And then with that, we try to resect the tumor. And I just wonder if you have any data that could actually explain the difference between intraoperative MRI and that of ultrasound. Thank you.
Alex, maybe I'll ask you to, or Cameron, I think you go with it. Yeah.
I haven't used intraoperative MR, so I don't really know much about that. But I think you can get a lot out of intraoperative ultrasound as for removing as a very good deal of the tumor. What is kind of an obstacle is that at the time when you really need the image quality the most, towards the end of operation, when there is little tumor tissue left, then you get some enhancement artifacts. I will come back to that in my talk. If you can get rid of that enhancement artifact, I think ultrasound could be just as good as intraoperative MR, or at least at about just as good as intraoperative MR.
So I am the birthplace of intraoperative MR, and we have our second generation intraoperative MRI scanner, which I'll talk about a little bit. And despite the fact that we have access to intraoperative MRI, we still use intraoperative ultrasound a lot for its benefit in terms of not disrupting the workflow, much lower cost, available. For example, we only have one intraoperative MRI and we normally have 7 or 8 rooms running. And it does require more experience to make correspondences, because as was noted earlier in Dr. Padacce's talk, we are more used to looking at intraoperative MRI, and we're more, preoperative diagnostic MRI, and we're also more used to looking at the cardinal planes, axial, sagittal, coronal. So the interpretation of the image is more straightforward. And that speaks to the need for experience and also some tools which might, and I know Professor Unsgaard is going to present some of these that help make the ultrasound image more useful to the surgeon. Also, one of the challenges with ultrasound is the lack of persistence of the image. So with a conventional probe, if you have the probe in place, you have an image. The second the probe loses acoustic coupling, you won't have the image anymore, which limits its utility. And I know Professor Unsgaard is going to talk about some of the solutions to those challenges.
And you mentioned that you didn't have access to a radiologist. I think that is good, actually, because you should not let the radiologist take over this process. You should do it yourself. You should learn how to use ultrasound yourself. That is very important to make it useful in the operation theater.
Yes, completely agree. We actually started using ultrasound much more when we were able to do it on our own without a radiologist present. Just decreased the obstacles. Well, I guess that's it for questions. Professor Padacce, would you introduce our next speaker, please?
Thanks so much, Alex, with the greatest of pleasure. So it's a huge pleasure for me to introduce our next speaker, Professor Gamund Ungsgaard, who was professor at the Norwegian University of Science and Technology for over 30 years, dean of the medical faculty for the last 6. He's been chief of neurosurgical department at St. Olav's for 22 years, and last 15 also as a head at St. Olav's University Hospital. So well over 220 scientific publications. His research encompasses cell biology, MR technology, especially over the last 2 decades, mostly around the use of ultrasound technology in neurosurgical procedures. He developed the concept of navigated 3D ultrasound in neurosurgery and really almost single-handedly turned the little town of Trondheim into the epicenter of ultrasound-based imaging for tumors, especially low-grade gliomas. He's used it for many years. He's entrusted different international positions, and I think most notably was knighted by the King of Norway in 2009, received the Knight of St. Olav's Order as an underscoring of the kind of quality of his science and professional work. So it's a great pleasure to introduce Professor Ungsgaard. Gamund, if you want to get started.
Yeah, thank you, Llewellyn, for that generous introduction. I'm going to speak about my experiences from everyday use of navigated 3D ultrasound in brain tumor surgeries. I have a disclosure, medical advisor for Sonoclear. I started to use navigated 3D ultrasound in 1996. At that time, there was no equipment available, so we made our own equipment, the Sono 1, which is a integration between an ultrasound equipment and a navigation system. And when we built our new neuro center, that was in 2005, we had the chance to get an intraoperative MR, but we decided to stay with the 3D ultrasound because we had a lot of positive experience with 3D ultrasound for many years. It's flexible and inexpensive solution that met our needs. It has a low capital cost, it has no imaging hazard, it takes only 30 seconds to prepare a scan, and the soft tissue quality is usually very good. Of course, there are some challenging learning is needed to benefit from intraoperative ultrasound, and that is the reason why we have this webinar tonight, and also why we have this group of professors doing intraoperative ultrasound courses in different parts of the world. And also the reason why I used to have these international training courses in Trondheim. And this is from one of these courses, live transmission from the operation room. The patient is a young lady with a tumor immediately in front of the precentral gyrus. Acquisition, 3D ultrasound acquisition from the dura, showing the tumor rather well. And already now you can see when we are making the biopsy that the pre-op navigated MR is way out of range. We don't even hit the tumor with that, but we hit the tumor because we trust the ultrasound. And that is because of a considerable brain shift that has already occurred that early in the operation. And I like to use navigated CUSA in my tumor resection. In that way, I will see the tip of the CUSA in the image. The image will always move around so that the tip of the CUSA will be in the image, and I can see the distance from the CUSA tip to the border of the tumor. And here you see towards the end of the resection, gross total resection, and that was confirmed with MR 1 day after the operation. And the patient had a small temporary paresis in the right hand due to this small ischemic lesion in the precentral gyrus, but fortunately it disappeared in a week. The most important point for ultrasound-guided operation is the image quality. And at the start of the operation, it's easy to obtain ultrasound image quality that is just as good or even better than MR. You see here pre-op navigated MR and the corresponding ultrasound image, and you can see more details in the ultrasound image. Low-grade glioma, another low-grade glioma, and high-grade glioma. You can also see more image details in the ultrasound image than in the MR. Here, with this cystic tumor, you have an enhancement artifact underneath the cyst that is reducing the quality of the image. But towards the end of the operation, it's difficult to keep the quality of the ultrasound image, and that is at the time where you really need high quality. There are some requirements that you should be aware of. Optimal positioning of the patient. You should have a horizontal craniotomy and a vertical excess. This will not do. That can, in my opinion, always be obtained in supratentorial tumors. The most challenging is immediately in front of the central sulcus, where you need a supine position with flex neck, and also behind the central sulcus, where a modified park bench position will do. You need to have obtained hemostasis. You should remove spatulas and surgical patties when you are acquiring images. Air bubbles will not be any problems because they will surface when you have a vertical excess. So the big innovation of the 90s was the neuronavigation, the navigated pre-op MR. Ultrasound and navigated pre-op MR have a different strength and abilities and limitations. And the navigated pre-op MR has a large overview and I would say a lousy accuracy. In intraoperative ultrasound, you have a high accuracy and a limited overview. And the overview of the MR and the accuracy of the ultrasound can be combined by navigated 3D ultrasound. The way you do it is to have a... Pardon?
Could everyone be sure they are muted, please?
This is why it doesn't make sense. Initially, when we were...
Yeah, the way...
Sorry, Garman, I think we can mute everyone.
Yes, they won't pay you. And they will take as paying their patient and now pay a fraction. If the bill is too enough, they give you 350 and they will take the rest. Is that, does it make sense?
Can you hear me now?
We can, yeah.
I think it's been fixed, yes.
Yeah. The way you acquire 3D ultrasound volumes is that you have a navigated probe and move the probe over the area of interest. And you start where you cannot see the lesions, go past it and finish where you cannot see it anymore. You need to have some normal tissue on both sides of the lesion. And you can also move this probe over the area of interest in one swipe. You should always try to do that, but if you cannot, then you can do several swipes. And then different pressure and also some difference in the quality of the navigation system can make this a little bit reduced quality, but this is not a big problem actually. With navigated 3D ultrasound and integration with the pre-op navigated MR, it's very easy to immediately see the brain shift. It also makes the interpretation of the ultrasound easier. This cyst could cause this artifact underneath. It could cause this signal underneath the cyst as an artifact, but by comparing with the corresponding cross-section of the pre-op navigated MR, you will see that this is also tumor. So it helps you to interpret the ultrasound. It will also help you to follow the progression of the operation. Here, there is a lot of low-grade glioma tumor left. Here, much less left, but still some tumor tissue left. And this is a glioblastoma. And you can see here a very big tumor. During resection, you can see how the border between the tumor and the normal tissue is creeping towards the center of the tumor. And at the end, you have a cavity that is much smaller than the original tumor. That was confirmed also by the postoperative day, postoperative MR, 1 day after the operation. It showed gross total resection. The patient had no neurological deficit, but the shift of normal tissue is quite big. The cavity is less than 1/3 of the original tumor. And that tells us that navigation based on a pre-op MR is not reliable. You should not trust it. Then you can get in the problem of resecting normal tissue. You need an update. You need an update during the resection. And the only technology that can give you updates several times during an operation is the ultrasound. And navigated 3D ultrasound also enable the use of navigated instrument, like navigated ultrasound aspirator, the IOUS, and a navigated microscope. We are used to use this axial, coronal, and sagittal display. But it has its drawback. It can be used with navigated microscope, but with the navigated IOUS, it has its drawbacks. It's difficult to percept 3 moving planes at the same time. And we know at least one of these planes has a reduced quality as well because of the probe. The probe has an axial and a lateral plane that is the best, and the elevation plane, the thickness of the image is usually rather too thick to make a good 3D ultrasound image. So we should be aware of that when we are using our display techniques. So one technique is to use this dual aniplane, where this upper image is more or less parallel to the probe that has acquired the image. And then you have an orthogonal plane perpendicular to that plane, more or less for orientation. I think the absolutely best view is, display technique is to use the tip view. This upper plane is parallel to the probe, more or less, as shown in this blue square. And the lower plane is showed in the red square, and it goes through the tip of the instrument. And here you get both best qualities of the ultrasound probe, the axial and the lateral. And you get a very good image quality, and it's also very intuitive because you get an image that is more or like identical to what you see in the microscope. This is a tumor of a boy with he had a tumor in the occipital lobe close to the close to the optic radiation. And it's difficult to plan this to get into the tumor without harming the optic radiation. This was the chosen approach. And here is the ultrasound acquisition, and you see the tumor, and with a navigated pointer, you can, or the virtual pointer, you can point around, make a biopsy of the tumor, and then start to use the navigated CUSA. Did it stop? Yeah. And continue with the navigated CUSA for a while. Try to remove as much as possible, then make a new ultrasound image. You see there is still some tumor tissue here. Then go on with remove the remaining tumor, and then you see this is how it looks like towards the end. Everything seemed to be removed, gross total resection, and everything was done through a very small opening in the cortex. Very small opening, and the patient didn't have much. He had some blurring of his vision, but he didn't have a hemianopsy afterwards. You can also, as was mentioned by Llewellyn, can use ultrasound to depict vessels. I like to use the power Doppler angiography because it has a high sensitivity. It gives good images of small vessels, and it's not dependent on the probe position. And it is, I have used it a lot in AVMs to identify feeders. Navigated 3D ultrasound angiography by power Doppler. There you can clip the feeders early in the operation, and that makes the AVM operation into a much easier operation. You can also use it for this lenticular striate arteries that you have in large insular gliomas, and where you come very close to this, and sometimes are in the position where you more or less can destroy these vessels, which will give hemiparalysis of the patient. So you should really try to avoid this. And by having this identified by the power Doppler in front of your CUSA, that will help you a lot in these operations. I like to use navigated CUSA in operations where I have to go through cortex, normal tissue, like in this insular glioma. Most neurosurgeons would probably operate this through a Transilvian approach, but as you see, the image quality is very good in the ultrasound image, and I think it's much more elegant to use to remove this tumor through a transcortical resection guided by navigated 3D ultrasound. Then you can do it through a very small opening in the cortex, and you can do 3D ultrasound angiography to identify the insular vessels, and you can use the CUSA in between the insular vessels, and then gradually remove more and more of the tumor. And at the end, everything is removed. Every tumor tissue is removed, at least the visible part of it in the ultrasound. And you have these vessels, insular vessels, hanging freely in the cavity. And this patient, this was on the dominant side, and the patient was very well a few hours after the operation. MR showed gross total resection, and everything was done through a very small opening in the cortex. Navigated QSI is especially useful in deep-seated lesions with narrow excess, like in these two young men, one with a tumor on the right side, close to in the insular region, and the other on the left side in the same region. This patient B had been operated on at another university hospital. They tried to reach this tumor through a Transsylvian approach. I think this is the scar from that operation. They didn't reach the tumor, and they sent him to me to do ultrasound-guided resection of this tumor. And this is how it looks like one day after the operation on MR. Gross total resection on both. No neurological deficit, except that patient B had a hardly noticeable paraphasia. The way I do it is a temporal incision, and then a craniotomy as far down to the zygomatic arch as possible, and then try to go as far down on the temporal lobe as possible and into the tumor. And this is from one of these patients. This is the one with the tumor on the right side. And you see, here you see the tumor. And take a biopsy. This is the target for the biopsy. And then start the resection with navigated QSA. And you see here is the tip of the QSA. You can always keep that within the border or that you see in the ultrasound image. And after a while, a new ultrasound image showing that there is still some tumor tissue left. I'm not able to see it because your images so is shown in in this right side of my screen, but yeah, simulation, and that then is showing at the end that everything is removed. And the other patient, on the left side, and you can see how close you are here to the pyramidal tract and also to the optic tract. So, and also to the big vessels here. So it's not easy, but it is safe as long as you can really trust the ultrasound image. And for this patient, at the start, during the resection, and at the end where everything is removed. So to the results of my ultrasound-guided low-grade glioma operations. Some of you might have heard about this study that we did in Norway many years ago. At the time where there was no consensus about how to treat the low-grade gliomas. Then at one university clinic, the strategy was to do early surgical resection, and at the other was the strategy to do biopsy and watchful waiting. And Jakola was the PhD student of mine at the time. And I was the one that did the 3D ultrasound guided operations. And this study was possible because of the organization of healthcare in Norway, free healthcare and regional organization. And all patients are referred to their own university clinic, so you get in a way a randomization by postcode. And it's a robust material because all patients with astrocytoma grade 2 were included, also patients with gliomatoses cerebri and also poor functional status, patients that could not be operated, but they were included in the material. And the survival of our patients was 14.4 years, of course, much shorter at the other hospital. But what was important here, I think, is that there was no difference in adverse events by doing early surgical radical resection with ultrasound guidance compared to doing biopsies. Later, this first material was up to 2009, and this other material PhD student looked through, this is also a robust material because I tried to remove as much as possible of tumor material also on diffuse infiltrating tumors in eloquent areas to try to reduce the chance for malignization. And the median resection grade was 93%, gross total resection 30%, and the quality of life was maintained or improved in 86%. So it shows that the 3D ultrasound guided low-grade glioma resections under general anesthesia is a safe procedure with an extent of resection that is consistent with the other studies published at the time. But of course, there is room for improvement here. And that is because of these enhancement artifacts that can be a big problem for ultrasound image interpretation. There are several ways of reducing this enhancement artifact. And one of these has been mentioned several times already. That is to use a small high-frequency probe in the cavity. Then the distance from the probe to the cavity wall will be reduced, and this will reduce the noise. The disadvantage is, of course, a reduced field of view. It's a little bit cumbersome to use, and it also has the potential risk of harming tissue by manipulating a probe in the cavity. This was an operation I did about 11 or 12 years ago now. I was very satisfied with the ultrasound image, very good ultrasound image quality, even better than the MR FLAIR as for delineation of the tumor. But I was very disappointed at the end of resection where I had this enhancement artifact that really destroyed the image quality. And we decided we had to do something with it, and together with an engineer that I have been working a lot together with, Tormod Selbekk, we decided to do a project under the National Advisory Unit of Ultrasound and Image-Guided Therapy in Trondheim. That is a cooperation between Norwegian University of Science and Technology and the research organization SINTEF and St. Olav University Hospital. And we came up with this brain mimicking fluid with two crucial characteristics. It has about the same attenuating or damping effect on the sound waves as the brain, and it is not visible in the ultrasound image. We tested the safety of this acoustic fluid in animal experiments, in rat and in pig. No adverse events was discovered. And I started a clinical study This is the first patient. And the attenuation coefficient of ultrasound waves in water is very low, while the attenuation coefficient in brain is very high. And that creates this chaotic signal at the bottom of this ringer-filled cavity. By removing the ringer and using this acoustic coupling fluid, which is a fluid and not a gel, you can see that all these artifacts are removed, and you can see tumor tissue in the cavity wall here. I did phase 1 technical and safety study of 15 glioblastoma patients, and the adverse events in this study were within the limits of what have been reported in other glioblastoma publications. And as for the image quality, I can show a couple of examples. This is glioblastoma along the falx and corpus callosum in coronal and sagittal view. And you can see towards the end of resection with ringer in the cavity, it's impossible to interpret the image here. While filling the cavity with acoustic coupling fluid, you can see there is still some residual tumor here, but along the corpus callosum, everything is removed. Another case, occipital glioblastoma. After having removed part of the tumor, I did a new ultrasound acquisition with ringer in the cavity. And you see on the probe side, it's easy to see residual tumor here. But on the other side of the cavity, it's very difficult to interpret the image. So by filling this cavity with ACF, you can see this satellite tumor, and you can see also that there is tumor underneath the falx. And this is how it looked at the end of resection. Everything was removed. So we made pair of images from each of these patients, one with ACF and one with ringer in the cavity, and gave them to 5 independent neurosurgeons in a randomized and blinded way, and asked them to score the image quality according to a scale of from 1 to 10, where 10 is the best, and asked them to answer these 3 questions about image quality. And as you can see, ACF, it came out highly in favor of ACF, all these questions. So, of course, intraoperative MR is the gold standard for intraoperative imaging. It has a very high quality, but it has also some problems with prolonged surgery, and it's expensive and so on. And our thinking was that if we could remove these artifacts that you have on the ultrasound image, because ultrasound image is faster, easier to administer, and less expensive, but it has these artifacts that really remove really reduce the ultrasound quality towards the image quality towards the end of the resection. And if we could remove these artifacts, maybe then it will, like here, you will see residual tumor, you will see residual tumor, and you will see that everything is removed. Then maybe ultrasound with this acoustic coupling fluid could be a very good alternative to intraoperative MR. And the research organization SINTEF was very interested in spreading this knowledge to the neurosurgical community, and a company was established with some private investors And this is the product, a pre-filled syringe with fluid with an acoustic properties very close to the brain and tumor tissue. And now we are doing a clinical study in Europe. The protocol is to include 45 patients. I think today we have 43, so it's very close to being finished. These 5 places are the places that have included patients. These 2 places have been delayed in acceptance, and so they will not have the chance to include any patients. So this is how it looks like in one of these centers. The first image, the first patient in one of these centers with saline in the cavity, you see a lot of enhancement artifact. With ACF in the cavity, you see a much more crispy image where you can see the tumor borders much better and make it much more easy to remove the last part of the tumor. At another center, a low-grade astrocytoma, also their first patient, and you see with ACF a very crispy appearance and a very easy to identify the tumor borders. While with saline, it's much more difficult, and you get which is certainly an enhancement artifact here. Yes, thank you. I think this ACF can eventually really be a good help for a lot of users of intraoperative ultrasound. Thank you.
Thank you, Professor German, for your amazing speech. I really enjoy it, and I'm sure that everyone, all the participants enjoyed all these informations and science sharing. Levlin, is there any question for Professor German?
No, I don't. I think if you look at the quality of the imaging on that acoustic coupling fluid, you've been asked this many times before. I think it makes a major difference. So just maybe, I think you mentioned at the end, by the end of this year, if I remember correctly, is that about the time that you think something like that would be available?
I will not guarantee that, because there is a lot of obstacles in the regulatory system. But at first we have to finish the study, and then there is after the last patient has been included, we have to wait for half a year, because there is a quality control half a year after. And then there is a long time after that, I think, until we can expect some clearance or some acceptance by the authorities. So I am really. It takes much more time than I really thought in the beginning, I must say. I think there is a couple of questions here.
Yes, please. I have a question, and I raised my hand. I don't know if there are many people, because I had gone off.
I didn't hear your question. Could you repeat your question?
No, I didn't even ask the question. I was just saying that I have a question. I never actually asked it. Now,
okay.
So this is Professor Kaba online again from Ghana.
Mm-hmm.
And I have some few questions to my host, which I think we should be able to deal with them ourselves. Now, I use neural navigation, okay? Stealth S8, okay, from Medtronic. Then I use the ultrasound as well. So I try to couple the S8 together with the neural navigation. I have detected that anytime you're doing that, there's a 1 millimeter difference between the live, which is ultrasound, and the delayed, which is the S8, especially when you open the bone, especially when you take off the bone and you're on the dura. Please, can you tell me your experience in measuring that kind of difference to get to the tumor?
I don't know. Of course, it's important that the navigation system and the ultrasound probe is very well aligned. The system I used, that was an integrated system, so it was integrated from the factory. So we knew that it was correct, but when you use different probes and different navigation system, you have to make this work together in a precise way, and maybe that's not always so easy. I don't know. Maybe that could be the reason why you have some discrepancies.
All right, thank you. So the difference is this: whenever I'm using the ultrasound and I use the navigation probe, I find a difference. And the difference is that the navigation system wants.
Oh yeah, you are using
ultrasound tells you live.
Yeah, you are
and
not.
Then I find the difference in especially in awake surgery, which I did quite recently. Then when you come in with the neurostimulation and brain mapping, I found that to be so different. Because when I put the neurostimulation on a place in the brain, it's totally different from the navigation system with 1 millimeter difference. And that was what I wanted to know, if you have that experience.
So it's the navigation system that just don't fit with the ultrasound. Is that what you say?
Yeah. So what I'm saying is, I fixed the ultrasound to the.
I think you should always trust the ultrasound, because ultrasound is the most precise and most up-to-date information that you have. The neuronavigation as such is based on a lot of assumptions that you have to do, a lot of technicalities, registration and all this, and it's not always that precise, actually. I think we lost him.
I think so. We have a question also from Professor El Abadi.
Yeah, this is
okay. Sorry.
Yeah, come on. You are on now.
Yeah.
I think it's difficult to hear what you say, actually.
Sorry, I have some problem with my connection. Hi, Alex. How are you? So, because the iPhone.
So sorry, I was lost. So sorry. It's in.
Yeah.
Okay,
Yeah. So sorry, I was lost.
You are hearing me?
I'm back. I'm back.
Yeah.
So what I was saying is that from my neural navigation system, let me be more specific, is Medtronic's Stealth S8, their new generation. And then I couple it with I put it together with the ultrasound. And then I found out that there is a 1 millimeter difference.
Yeah.
Okay.
I think we lost him again. Yeah.
Maybe we can take the question from Professor Najia Al-Abadi.
Yep.
Yeah. Let's do that. Professor Najia.
Okay, thank you so much. Yeah.
We're not able to
You are me? You hear me?
It's difficult.
Yeah.
It's difficult.
Can you try stopping the video?
Yeah,
See if
yeah,
we get
Hello?
better.
You receive our voice? No? Okay.
Fad, your network is not very good, so maybe you can stop your video so that we can hear you properly with your current network. Just stop your video. Yeah,
You are hearing me now?
yeah,
now?
we can hear you now. Please go ahead. Yes.
This is what is doing. It's okay now? Are you hearing me now? Oh, it's good.
Yes, we hear you.
First of all, I would like to thank all of you for this really amazing webinar, because we had many webinars, classical webinars. If I have to say, I would to say like the pathologies, and less webinar with innovative devices, and especially with ultrasound. It's the cost is not very important, and we can sometimes thinking about to have MRI, perioperative MRI, and CT scan MRI, etc., or with this in perioperative, because even the neural navigation for sure is very important, because we cannot use it. And my question is, we can use the ultrasound before the craniectomy. It's not very important. Is it very useful before the craniectomy? And the second thing, in my opinion, I'm sure that using the ultrasound perioperatively, it's more interesting and more useful than the neural navigation, because the shift with the neural navigation we didn't have it with the ultrasound. And my last question, this is only comment, but my question is, the learning curve is really very interesting cost for this technique, and learning curve, in my as a neurosurgeon senior, it's how many times for every lesions, even if in infratutorial, for example, very close to some EC, for example, for ECP angle or others lesion, very very close to the skull base. This is my question.
I didn't really hear.
Is it clear or?
I think we lost you on the third question. I think we lost you on your third question. The first question was about
the learning curve.
Yeah, the third question was about the learning curve. Okay, the first question was about using ultrasound before opening the cranium, and that is not possible. You have to do a craniotomy to be able to use the ultrasound. And the second question was about
in some area close to the skull base, for example, ECP angle, etc. Is it is it useful as a tumor systematic or not?
Yeah. It can be used
your answer is yes.
Yeah, it can be used. You can use in also in the CP angle. I have used ultrasound for acoustic neurinomas or schwannomas in the statoacousticus, and that functions very well for identification of the tumor borders and all this. As long as you don't put the patient in a sitting position, then you have a problem. It cannot work with the patient in a sitting position. So, and the learning curve, yes, I think you should try to use ultrasound in every operation where it's more or less feasible, even though you really don't need it, because then you get used to it. I think that is the way to learn. If you just put it, take it and start to use it when you really need it, then you will have trouble, because then you haven't experienced how it really works. So I think that is important. But I would think that if you have used the ultrasound for 10 or maybe 20 operations, you start to feel comfortable about it.
Okay, thank you so much. And thank you for all the speakers for these wonderful talks. And hello, Alexandra.
Yeah, hello. I'm back.
Mm-hmm.
Yeah, hello. Can I be heard?
We hear you, Samuel. Yeah.
All right. Yeah. So what I was talking to you about is the use of the ultrasound, because I use ultrasound every day for hydrocephalus, for many tumor surgeries. And I was saying that when I use the ultrasound and I couple it with the neuronavigation, Medtronic Stealth S8, which is the latest, I found that there's a 1 millimeter difference between the navigation and the ultrasound. What is your experience on that? Because when I'm going deep into brain surgery, the distance of 6 to 10 cm, I cannot identify much beside the microscope and the ultrasound. What is your experience once you open the craniotomy, once you take off the bone? What has been your experience on that?
Alexandra, do you have any?
Well, I think the The answer is that the navigation has many sources of error, both rigid and deformable registrations. So the accuracy actually can be off by even a centimeter at certain points during the surgery. And it's not a problem with the navigation system, it's just the nature of that technology. And the benefit, one of the key benefits of the ultrasound is that it is real time. And so it is reflective of things that may have happened, like brain shift or shift of the patient. I would say 1 millimeter is actually really low amount of discrepancy. People have found considerably more than that just from ordinary registration.
Yeah, I agree. I absolutely agree with you. And it's important that you should always trust the ultrasound image and not the neuronavigation in those cases.
So
I tend to agree with you.
Late. So I think we should probably move on.
Move on to the next talk. So allow me to introduce myself first. I'm Dr. Sachin, the co-moderator with Dr. Fahd here. And let's move on to our third talk. And allow me to introduce our next speaker, Dr. Alexandra J. Colby. He's a neurosurgeon and director of image-guided neurosurgery and a co-director of advanced multimodality image-guided OR and director of clinical fMRI service at Birmingham and Women's Hospital in Boston. She's professor of neurosurgery and professor of radiology at Harvard Medical School. She holds the Halley Distinguished Chair in the Neuroscience at BWH. She's also principal investigator of Golby Lab, a surgical brain mapping laboratory. She has special interest in brain surgery for patients with brain tumors and epilepsy, especially those lesions which are intimately associated with the brain structure. She has authored over 150 peer-reviewed publications. Her translational research is focused on advanced imaging and image guidance to improve the care for the patient undergoing intracranial neurosurgery. She has developed numerous technologies to help guide pre-surgical planning and intraoperative decision-making. She works closely with the scientists across many disciplines, including the computer science, applied mathematics, MR and ultrasound physics, and biomedical engineering, and is also involved with mentoring young clinicians and scientists. She was recently named a Fulbright Global Scholar and will pursue work in interdisciplinary collaboration between technical experts and clinicians in host countries, Rwanda and Morocco. So with that introduction, allow me to ask Dr. Alexandra to kindly share her screen and speak on her topic titled Intraoperative Ultrasound Neurosurgery, Current Use and Future Direction. Over to you, Dr. Alexandra.
Thank you very much for that extremely comprehensive introduction. I'm very pleased to be here. And of course, one of the challenges of following two luminaries in the field and speaking about innovations is that they've already covered much of what I will speak about because they are the ones doing this innovation. So let me share my screen. And also, I appreciate that we are coming up on the 2-hour mark. So I will go quickly. Can you see my screen?
Yes.
Yes, we can see it and we can hear you.
Great. So as mentioned, I come from Brigham and Women's Hospital and Harvard Medical School. And we have, of course, a long history of innovation, starting with Harvey Cushing and the invention of the Bovie instrument in collaboration with his biomedical engineer at the time, and then moving on to intraoperative imaging. So I'm going to speak a little bit about some innovations. I should say, in terms of disclosure, I do work with Insightech, which is a company developing image-guided focused ultrasound, as you heard a little bit earlier from Llewellyn. I'm not going to talk about that at all today. And as you've heard, intraoperative ultrasound is an old technique. It predates CT and MR, but we've had this renaissance in large part due personally to Professor Unsgaard and his work, but also due to improvements in technology, including the image quality, the smaller footprint of the probes, allowing it to be used in small craniotomies. And then I think very importantly, the innovation that was developed by Professor Unsgaard of 3D reconstruction by linking it to the navigation system. And clearly that innovation was about a decade ahead of everybody else. And even in a setting such as ours, where we have all the resources, including intraoperative MRI, we are using ultrasound more and more because it's such a flexible tool that allows us to use it in quickly without disrupting the workflow, without dependence on any technologists to help with it. And it can be deployed in many situations in which intraoperative MRI is very difficult. Intraoperative MRI can be quite difficult in awake surgery, in the posterior fossa, and it can only be used by one surgeon at a time. So I really have become a very big user and proponent of intraoperative ultrasound. And you've heard about all of its uses from the leaders. I'm going to speak a little bit about some of the current state of the art and research and some future directions. So as I said, the intraoperative MRI is something that was developed at the Brigham originally in the early 90s, and now we have a state-of-the-art system. But this is what it requires to get an intraoperative MRI: disrupting the surgery, placing the head coils, redraping the patient, counting all the instruments to be sure there's no metal in the room, and then moving that many-ton magnet into the room. And this whole process takes about 90 minutes. In contradistinction to that, we use the ultrasound multiple times during the surgery. We use it before dural opening, immediately after dural opening, and during the tumor resection itself in ways that you've heard about. Interestingly, we're also looking at it immediately before the intraoperative MRI, because we have the opportunity to use the intraoperative MRI to validate what we see on intraoperative ultrasound. And recently, we've also started taking an ultrasound immediately after the intraoperative MRI. And the reason for that is that the 90 minutes of the intraoperative MRI actually causes more changes in the brain shape and the shape of the cavity. There's also a repositioning of the patient, so the effects of gravity are different. So that's to say that even an intraoperative MRI does not necessarily give us perfect information. And even though it's closer to real time, it's still not actually real time the way intraoperative ultrasound is. This is just how we do it with a tracked probe. And that allows us to make the image persistent, which I think is very important. Anybody who's used a simple ultrasound probe without the adjunct of navigation knows that the picture is good when the acoustic coupling is perfect. But if the surgeon even moves their head to look at the screen, they may lose the coupling and lose the persistence of the image, so making it difficult to perceive the image. And then by making a sweep, we can make a 3D reconstruction so that the image can be seen in any plane. which can help with the challenges in interpretation and the learning curve that you have heard about. So how can we make the techniques as informative as possible and specifically help in that adoption and learning curve? So one approach that's been proposed is called ultrasound-oriented surgical planning. And basically, this is using the navigation system ahead of the surgery, planning the trajectory, and then reslicing the volumetric imaging study, either CT or MR, in the plane of the planned craniotomy and of the planned acquisition. And this basically is a very simple process. It's just a way of visualizing ahead of time. So this lesion, lesion in the temporal lobe there, you can see how it would actually be positioned with the craniotomy horizontal, as noted by Professor Unsgaard, to facilitate acoustic coupling. And it gives the surgeon a chance to preview what the actual configuration might look like of the tumor when they are actually approaching it intraoperatively. So it doesn't change the intraoperative imaging, but it may help place it in a context that's more familiar. And I did want to note that process that was described requires a navigation system. And as you know, they are very expensive, costing hundreds of thousands of dollars. But all of those steps could be accomplished with some open source software. This is software that was developed initially at Brigham and now has hundreds of thousands of users. And also my colleague, Sonia Pujol, is spearheading an effort to internationalize Slicer so that it will be available in many languages. And so that would allow you to do that preoperative planning ahead of time. There's a number of types of intraoperative ultrasound, including different techniques. So one technique is simple 2D ultrasound, and that has some advantages of speed and simplicity. But as we noted, it does not persist, and it makes interpretation often difficult. So 3D ultrasound has been developed. It can be accomplished by placing a tracker on the probe and using a navigation system to reconstruct the 3D image, and then it can be resliced in all the planes. There is also the possibility of a probe, which is natively 3D. So it's a mechanical transducer, but unfortunately, there are no probes approved for the use in the brain, and they are quite large. So this is something that is still to be developed in the future. Also, for those of you who have only 2D ultrasound, this study does note that in many cases, the quality of the image in the acquired plane is actually better in 2D ultrasound. And that's because it does not have to be reconstructed. So reconstruction of ultrasound into other planes is prone to loss of resolution because the acquisition will often skip slices or skip areas between the slices. So even a 2D ultrasound can be oriented in multiple different positions to get the total picture. So for example, a coronal acquisition followed by a sagittal acquisition can be integrated to make sense of the probe. I'm going to skip this because you've seen so many cases today, beautiful use of the technology. And I was next going to speak a little bit about acoustic coupling fluid, but you've heard from the inventor of acoustic coupling fluid, the advantages that it can provide in terms of reducing this signal artifact at the depth of the cavity, which is due to the impedance change between the fluid and the tissue of the brain. And as you've heard, there is a multi-center clinical trial going on in Europe right now, which is almost completed. So to speak a little bit about the use of non-navigated ultrasound, which I think is, I wanted to make this point because many of you do not have access to navigation, that some of the challenges can include demonstrating the tumor boundaries, but there is a high specificity for residual tumor. And then, as we've mentioned before, that it depends on surgeon experience. You also heard a little bit about the different uses of intraoperative ultrasound, which are still evolving. And this is from Francesco Prada's group and Francesco Di Meca's group, using these different types of ultrasound and how they can inform specifically tissue characterization. So not just localization of where is the tumor, but characterization, including using contrast enhancement to look at perfusion. In this panel, panel H, this is elastography to look at tissue stiffness, which can then be quantified. And one of the goals of this is to really better define the tumor margin. And that could be even potentially better than any existing modality, such as MRI, because we know that in gliomas, the tumor cells extend beyond the MR visible abnormality. And so the use of these additional techniques and others may eventually help us guide us towards the tumor margins. And as was noted and also alluded to in a question, the main goal of intraoperative ultrasound-based registration, when correlated with the navigation, is to update that navigation for its inaccuracies that develop due to issues of registration and also issues of brain shift. So to start with issues of registration, the navigation is registered off of the patient's face largely, and then the skull surface. So we do what I call head registration, but what we're doing is brain surgery, not head surgery. And so re-registering at the point in time at which the brain is exposed can produce a much more refined registration. So this is work that my colleagues and I are doing using non-rigid registration based on ultrasound. And the idea here is that there are many features detectable on the ultrasound, and these features are indicated with the circles. And these can be detected in an automated fashion using certain algorithms, computer algorithms and machine learning algorithms. And by correlating the location of these features on preoperative, early intraoperative, and later intraoperative imaging, we can correct for this type of brain shift. So you can see in the second picture here, the correction that can be applied. This is an example of applying that correction and creating a visible movement of the tissue. And this is just another way of displaying the same information, but I think it speaks to something you were shown by Professor Unsgaard, which is that it takes place in the cavity. And by animating this with a series of ultrasounds over the course of the surgery, it becomes much more understandable to the surgeon. So we're taking the same information and making it more understandable. You can also see there some of the deformation that happens even from the placement of the probe itself. So these are just other quantitative approaches to measuring and modeling brain shift, and then applying it to create a virtual MRI. And this was applied to a number of data sets. So for those of you who are interested, There are 2 existing data sets of intraoperative MRI and ultrasound, which can be used to understand better the relationship between these different modalities. These are the RESECT and BITE databases. We also have just curated the largest data set of intraoperative MRI and ultrasound, which is the Amigo Remind data set. And this is 114 cases of annotated intraoperative MRI and ultrasound images that can be used to study brain shift and to create algorithms to help interpret these images. I'll just make one more point, which is once we can model the brain shift, we can apply it to the images that we have preoperatively. So if we have advanced imaging, in this case, tractography, but functional MRI as well, they can be deformed to account for the brain shift that's occurred. And this is demonstrated by this work in Hassan Rivaz's group of the displacement of the tracts as a function of the surgery. So as you can see, this is much more than 1 millimeter of shift, and it's been measured in terms of the error, including up to 5 or even 8 millimeters. I also wanted to point out work that's being done presently, a multi-center study looking at the added benefit of ultrasound guided and function guided surgery in GBM. This would be a way of establishing prospectively the benefit in terms of outcomes of this technology. So far we have focused a bit on the benefit to the surgeon, but of course, obviously the surgeon is only part of the picture. We also, of course, want to benefit the patient. So I'm looking forward to the results of this randomized trial. And then I was going to speak just briefly about broadening access to intraoperative ultrasound. You've heard already about the use of point of care ultrasound. So these devices are quite inexpensive and portable, so that actually the surgeon can potentially have this themselves in order to not fight with the radiology department for access to the ultrasound machine, or in places where there is no existing ultrasound. This has really changed point of care imaging in places like the emergency room, obstetrics and gynecology, and you saw the potential use of this for ICP monitoring in the intensive care unit with optic nerve sheath diameter measurements. We've compared it quantitatively to our state-of-the-art BK ultrasound and looking towards sharing those data soon. This also can be very useful for training in the use of ultrasound. As has been noted, the learning curve can be steep, and training offline can be very helpful in terms of learning about the positioning of the ultrasound, anticipating the obstacles to good image quality. And you've already heard about this from our colleague Llewellyn of using this in the neurointensive care unit, and my colleague, Dr. Kara Kezi, who I was on the webinar earlier, to my knowledge, is the first person to use a point of care ultrasound intraoperatively. And we're really looking forward to her publishing the results of this. So that's a little bit of a whirlwind tour of some of the current state of the art and new directions and research that is happening. One of the key goals, I think, especially when we put this in the context of the WFNS, is to break down barriers to the use of intraoperative imaging so that as many surgeons as possible have access to this technology. And I think that the low-cost point-of-care ultrasound may provide that opportunity. There is also much in the way of opportunity to innovate using these tools in terms of measuring brain shift and other intraoperative findings, including the better definition of the tumor boundaries. So thank you for your attention to my talk. Thank you for your attention to our seminar and for hanging on for a little bit late seminar.
Thank you so much, Professor Golby. Is there any question?
I was just curious about getting a link to the Amiga Remind database because I was unable to locate this.
It is currently getting uploaded to the TCIA, the Cancer Imaging Archive,
Right,
and
cool.
will be there shortly.
All right, very cool.
Dr. Sashan, is there any question?
Yes, please. You can see my hand raised. Okay.
Okay. Go ahead.
All right. So let me. There are some historical perspectives that I need to clarify. Okay. In Ben Carson, one of the best neurosurgeons we can find on earth, spoke about the intraoperative ultrasound when he was using it in some hello.
Yes, we hear.
I don't know if I'm being heard.
Yes, we hear you.
Okay. So when he was using the Ben Carson was using the ultrasound in acoustic neuromas, I saw that clip myself, and it actually woke up to me. Now, in Ghana, where I practice as a Ghanaian, I use ultrasound for every little thing. Okay. And I don't think that it's an innovation, but I think it's something we have to improve on because we use it every day. Now, the issue here, and I was happy to hear that she said less than 1 millimeter differences, but it's between the neural navigation and the ultrasound. Ultrasound is live. Neural navigation is not live because when you remove the bone, then you have 2 millimeters of bone already removed, depending on the area you are, because the bone has its own limit. Now, what I have seen in my practice is that anytime you move that, there is a little shift, and that shift makes a whole lot of difference when you try to use the navigation to do like what I could call a biopsy. I don't know the speaker and myself if they have seen that difference between the navigation and ultrasound. I want to use ultrasound in the developing country like mine, where I only have the neural navigation in Ghana. I'm the only one who uses it because we don't have the equipment in Ghana. But in the developing world, I think ultrasound should take over and do a lot of work. So can I know your difference between the ultrasound and the navigation?
So thank you very much for your question. As was noted, the ultrasound is real time. And so it's going to be more reflective of the condition and location of the brain, including any brain shift that's happened. So that's just inherent in the two different technologies. I would posit that they are complementary so that the navigation is very useful for craniotomy planning. And that then once the craniotomy is accomplished, the two can be used together. So the navigation can be used to contextualize the ultrasound. But as was noted by all speakers, the ultrasound is the final arbiter given its real-time nature. So the two technologies are certainly complementary, because ultrasound cannot be used until the craniotomy window has been made.
Thank you.
Thank you. Are there any questions from any other delegates? If not, may I just ask an open question to any of the faculties? So at my institute, we use fluorescent sodium fluorescence for each and every case because it's very cost effective, costs very less. In India, it is almost $1 for that vial. So, and as compared to the other dyes. So, what's your take on if you compare, especially in the high-grade glioma? Of course, low-grade glioma, it's not an option. But in case of high-grade glioma, do you still use only ultrasonography, or you sometimes use fluorescence? And like, what's your take on that in terms of superiority or any limitations? Maybe Dr. Alexander can answer that first.
Well, I can't answer it from personal experience because I've never used it. In preparing this talk,
Okay.
I did come across a cost benefit analysis of different adjuncts for glioma surgery. I was just looking to see if I could find the picture, but basically they did an analysis of intraoperative imaging, such as intraoperative ultrasound, intraoperative MRI, 5-ALA, and fluorescein, and analyzed it in terms of cost per quality. So added 1 year quality of life. And fluorescein was by far the most cost effective at I think $300 or so per quality. And by comparison, 5-ALA was about $5,000 per quality, and intraoperative MRI, tens of thousands of dollars per quality. So it's certainly shown itself to be cost effective. The challenge is its specificity and sensitivity for tumor, so that it can lead to under or over resection in different circumstances, which of course, again, married to ultrasound especially of the quality that you've seen today, the two techniques can be very complementary, and neither adds a lot of time to the surgery.
Thank you. Thank you very much.
Okay, I have my hand up and want to ask a question. Now, in my center, I use the CUSA a lot. And when we send the samples, one sample is immediately we open the tumor, we take a sample of the tumor. And another one is during the surgery, we take this sample when we use the CUSA. Have you experienced any differences between the CUSA sample and that of the real-time sample? So we can say that, okay, because we use the CUSA deteriorated or made the sample not real. Thank you.
Any of the faculty want to take that question? Maybe Dr. Levlin, you want to take thought on that? Any difference on the CUSA sample and any pathological differentiation or assessment?
I'm not sure I'll answer that. I don't think so. I certainly don't have. No, let me just short. No, I don't think so. I'll maybe ask one of the other faculty.
I mean, we always put a bag on the CUSA so that we can send the material to pathology, and we have found that it's quite useful to them. It's not broken up to the degree that they can no longer look at histology. and also very useful for molecular studies if those are available.
Yes.
Yeah, I did ask this question because my pathologist came out with that, and he said, look, when you take the accuser, and there are certain tumors, they cannot define it. But when you don't do the accuser, it's different. And that's why I asked that question, just to be clear with what I do. Thank you.
Thank you very much, Dr. Samuel, to be very interactive and coming with your questions. So, are there any other questions from anybody? There's only one question in the chat box that is asked by Dr. V. Ping NG. He asked, dear professor, what is your thought regarding removal of all the hyperechoic lesion in the eloquent area? Will you consider the functionality of the area? Maybe Dr. Gedmund can take that question. If you put your scope and if you see a hyperechoic lesion falling on the eloquent area, do you consider the functionality of the area or do you remove that? I think that question is in respect to glioma, maybe, probably.
Yeah. Let me see. Is that the yeah. I think ultrasound is very unique in that way that it really measures the amount of cells in a way, how much cells are in a tissue. And if you have a tissue with a lot of cells, cell infiltration, then you will see it as hyperechoic area. But you have to evaluate, you have all other hyperechoic structures in the brain as well that you have to know about, so that you don't go into some real important structures in the central part of the brain or so, and so on, like the thalamic region and so on. So I think it is a challenge when you have a high-grade glioma that you see some areas that look like cell infiltration that could be edema. But most of the time, if you really use dexamethasone or some other steroids for some days, maybe 7 days, it will be much easier to know whether this is edema or cell infiltration. And there is if tumor has if a high-grade glioma has come as a result of malignization of a low grade, then you will get high-grade hyperechoic area, and then you will get something outside that might look like edema, but could be low grade. And it's always difficult to know how far you should go with that. But I think that is an important challenge for the future, to try to remove as much as also the low grade part of such a tumor. I don't know whether that really answered your question, but if you can restate your question, if you don't feel I'm answering your question.
I think you answered the question, Professor Uzgat. So there is no more question in the on the chat, or so maybe the chair of this webinar, Levlin or Professor Alexander Golby, can conclude the webinar. In my
can I ask a question?
I think we are
Out of time.
yes, we're out of time. We need to conclude. Thank you for participation and for your interest to the webinar. I want to thank all the speakers, Professor Uzgard Germant, Professor Alexander Golby, Professor Badayashi Levlin for their amazing talks and for sharing this innovative technology with all participants. The webinar is on the YouTube and on Neurosurgical TV. You can watch it again if you want. And
please, can I ask a question?
We are out of time.
Just quick one. If that has been used in stroke, hemorrhagic stroke, in ultrasound use in hemorrhagic stroke.
It's easy to see the blood in with ultrasound, but of course hemorrhagic strokes are not so often operated nowadays. So I did a study with removing blood from the cavity, the hemorrhagic cavity, with ultrasound many years ago, but I don't think this really came out with something that can be used in the future.
Thank you. Maybe Dr. Shemat, you can conclude the webinar. Thank you.
So thank you very much, all the speakers, Dr. Levlin, Dr. Gedmund, and Dr. Alexandra, for wonderful lectures about ultrasound in neurosurgery. Definitely useful for the young neurosurgeons. And this lecture is recorded and available on YouTube for all the young neurosurgeons who missed it. So it was a great session today with great interaction. So let's come to the end, and I declare that this is the end of today's session, and we conclude the webinar. Thank you very much. Thank you.
Thank you so much. See you soon in the next webinar. Bye-bye.
Bye-bye.
And thank you, everybody, and thanks to the organizers. Thank you.
Thank you, Dr. Samuel. Thank you very much.